is presented by Professor Raghava Mulukutla from Hyderabad, India. It's a very important talk and presentation about the surgical strategies in management of infections of the spine. Sir, you are with us?
Yes.
Thank you very much, sir, for accepting our invitation in this International Spine Day.
I would like also to add my voice in welcoming Professor Raghava Mulukutla for his attendance in this meeting, and we thank him in advance.
Thank you very much. It's my pleasure. I first and foremost sincerely thank Professor Muhammad Al Shahab for inviting me to give a talk, which is of course one of the easiest considering the more difficult ones that we heard. I also thank Benha University, the Department of Orthopaedics. And before I talk, we are one of the 2 oldest civilizations on this earth. And also true that the Egyptian medicine, which is one of the oldest medicines in the world, and so is Indian Ayurveda. These are some of the very old medicines of the world, which so we have a great heritage to look back and also to progress in future. I'm sure this talk today will be the beginning of a collaboration in spine surgery between India and the great nation of Egypt. And I look forward to that in future, and I'll keep in touch. Thank you once again.
Thank you.
My topic today is in surgical strategies in management of infections of spine. Can you see my screen?
Yes, it's quite obvious, sir.
Oh, lovely.
Yeah, it's quite obvious, sir.
Okay. Infections are basically pyogenic, non-pyogenic, fungal, or secondary to surgeries that we do. There are a lot of predisposing factors why one would get an infection. It is malnourishment, which is very common in countries like India, the third world country, and the immunosuppressed, which we see across the globe, and IV drug users, which fortunately are not that many in my country. Pyogenic infection is mostly Staph aureus. And in our series, 70% of our infections that we see pyogenic are Staph aureus, followed by Streptococcus, Pseudomonas, E. coli, Klebsiella, etc. A lot of our infections that we see in spine in otherwise non-ICU admissions are patients with urosepsis secondary to diabetes. And these people end up with a lot of gram-negative infections. So how do you manage them? Because my talk today is purely on surgery side. Any infection obviously would require a medical management, followed, of course, when necessary by the surgical intervention. In medical management, the fundamental thing to do is to identify the organism. Both in India, as well as in my stay outside India for almost 10 years, I've seen patients being treated without biopsies, without cultures, and by giving antibiotics of different kinds, only to get the patient to you ultimately with resistant bugs. So it's very important that you never ever start antibiotics to these patients without a firm established diagnosis. If there is an abscess, that should be drained. And I would consider that as a medical management, because you can see the infection here, the psoas abscess in a patient, and all we did was to drain it off, putting a pigtail there, and that would drain the whole abscess, and then you continue to treat them with antibiotics and so on and so forth. In our institution, for a pyogenic abscess of the spine or infection of the spine, we routinely give IV antibiotics, the appropriate antibiotics for 6 weeks. Following that, we give oral antibiotics for further 6 weeks. We immobilize the part by a brace, and we give sufficient analgesia. We obviously do serial blood tests and scans to see the progress and the response, progress of the disease, and the response of the disease to antibiotics. It's extremely important that the treating surgeon keeps a close watch on the deformity, if any, that is occurring, and any neurological deficit that may be taking place. And that is very important. So when do we operate? Look at this lady. See the foot drop. She's not only the inverters are working. There's a significant aorta weakness. There's a dropped toes. So these are the indications that there's a paralysis and you cannot go on treating them conservatively. Same situation here. You see here, there's a significant collapse of the vertebrae and there is a deformity that is developing. So if you see an impending neurological deficit or a deformity or the disease is not responding to antibiotics, you should go in for surgery. That's extremely important. What is your strategy? It's very simple. Like in any aspect of orthopedic management, you need to debride the dead tissue. You need to excise the whole of the infected tissue. That needs to be very, very thorough. You need to decompress the spinal cord and the roots. And you need to correct the deformity. If you don't, because of the progression of the disease, there will be further progression of the deformity and that can lead to neurological problems. And of course, once you do that, you need to fuse the spine once you correct the deformity. That's extremely important. You can do this by various methods, which I will show. Either you could do an anterior procedure or a posterior procedure or a combined procedure. Any of these procedures you can do. A pyogenic infection of the spine consists of a spectrum. It could be spondylitis, it could be discitis, it could be spondylodiscitis, there could be facet infections, and above all, epidural abscesses. These are very important and need to be aggressively treated. Once you see a pyogenic infection of an epidural abscess, I would jump in, especially if it is in the thoracic spine, because that is one area which is very unforgiving. If you see the epidural abscesses, most of them are in the cervical spine, about 90%, about 33% are in the thoracic or in the lumbar spine, depending on the type of infections. That also is very important. So any neurological deficit caused by an epidural abscess requires prompt surgical decompression. That could be associated with or without effusion. Now, this is a lady who went to a pain management specialist because of her coccygodynia and coccyx pain that she had following an injury to her coccyx. She was given an injection and that led to a block, an epidural block that led to infection, and she developed weakness in the lower limbs, high fever, and she was getting toxic. She was about 81 years old. So we went in, did an MR, and immediately decompressed spinal cord, and fortunately she recovered her weakness in the limbs and went on to make a good recovery. So whenever you see an epidural abscess, you do not procrastinate, go in, decompress, and then give appropriate antibiotics. As I said before, any pyogenic infection compressing the thecal sac has a greater chance of causing neurological deficit in the thoracic spine. So if you see any compression in the thoracic spine, you need a prompt decompression, because these are the ones who, if neglected, even though if the infection is controlled, they may develop a thoracic myelomalacia and spastic paresis or paraplegia. So that is a very bad thing to happen to our patients. So any significant compression on the thoracic spine, it should be addressed as early as possible. Now here's a patient, you can see here. This is the spinal cord that you can see. There is destruction, there's infection, there's an enhancement of the disc on T2 weighted image. You can see the vertebral subcondylar, there is a edema of the vertebral end plates, and you can see the epidural abscess causing compression on the spinal cord, as you can see here, and the slight altered signal in the spinal cord in the thoracic spine. This is again an indication for causing problems in later on. So we need to get in here. And in this situation, I did an anterior approach. You can see the lung being retracted, and you can see that the thoracic spine is exposed, and the appropriate vertebra is curated out, decompressed till we see a clear spinal cord free of any abscess or compression by any bony elements. Decompress the spinal cord. I turn and then we put an ideal crest graft in this area, and then turn the patient and put some pedicle screws. Sometimes if the bone quality is good, we don't need to do a posterior instrumentation. We can as well add screws from the front. Here we did an anterior posterior surgery, and this patient went on to do a good, for a good recovery of his Staph aureus infection. This is a patient who is 62 years old. He's a chronic diabetic. He was insulin-dependent diabetic. He developed E. coli infection of the spine, following, again, as I said before, urosepsis. This was treated on antibiotics for about 6 weeks with no decrease in pain, and gradually he developed weakness in the left foot and later on in the right foot, and then developed weakness in both lower limbs. This is the situation when we did an MRI scan, and then there was granulation tissue and pus in the epidural space not responding to antibiotics. So we went in from behind, did a laminectomy, decompressed the spinal cord, and then we instrumented the spine to stabilize the spine. And again, he was on prolonged antibiotics because this gentleman required, his CRP was not coming down, and it took about 3.5 to 4 months of antibiotic treatment for the patient's symptoms to subside, and he made a gradual recovery 6 weeks post-surgery. We are following him up now, and it's almost a year, and he's doing very well. And you could see that when you do this instrumentation, we have to maintain the thoracic kyphosis and maintain the lumbar lordosis to get a good sagittal profile so that there is no breakage of instrumentation. And when the patient's infection gets controlled, it doesn't end up with flat back or a sagittal imbalance. So we need to contour the rods and make sure that as when you're decompressing the spinal cord and debriding the spine, you also address the deformity that they develop. Here's a patient. She's 82 years old, diabetic, on insulin. She developed a chest infection, and she was treated for 6 weeks on antibiotics, oral antibiotics. At 6 weeks, she had difficulty in walking. She had gradual loss of power in lower limbs, and there was subsequent loss of bladder and bowel control. She came late to us because the family was worried about spine surgery in an 82-year-old lady. And at 12 weeks, when she came to us, there was complete paraplegia. She had continuing chest infection, and her constitutional symptoms got worse. You can see here, there is a pressure on her spinal cord. There is discitis there, and there is a lot of abscess. As you can see, infection, and there's also infection in her lung. You can see that this is a completely fluid-logged lung, and you can see the infection there. So what we did, I initially approached from the posterior side. I put pedicle screws. They were extremely loose. This was a case that I did long time ago. The screws had no hold. I wanted to use some the bone cement to augment the screws, but the anesthetist objected because he didn't want any embolism from the screws because she had only basically one functional lung. So I changed my tactic and I went on, I put a hard shell rectangle and put sublaminar wires, which is a very strong construct. And then I turned the patient around. I did an anterior approach. And this patient, again, the anesthetist said not to go through the good lung because he was of the opinion that if I go through the left side, that would cause press the good lung and compromise her oxygenation. So I had to go through the left lung, which was completely stuck to the chest wall. It took about 1.5 hours for me to gently separate the lung. We did it as you can see here, we did a thoracotomy here, transthoracic, transdiaphragmatic, retroperitoneal approach. We excised all the dead tissue there, and then we put some screws, and then we decompressed the spinal cord. We put a cage in the front and augmented that with a rod and screws from the front. So she had a posterior hard shell rectangle, sublaminar wires, and a screw fixation from the front. And fortunately, in a few weeks' time, she gradually recovered her neurological deficit, and at about 4 to 5 months post-op, she started walking and became an independent walker. That was a good result in an 80-year-old lady. In my country, we have tuberculosis every day. There's not a day a busy spine surgeon does not see a tuberculosis patient. This is rampant. The incidence of COX in the thoracic spine is, the spine is increasing, and a lot of them are treated with antibiotics, and they do extremely well. The only problem today that we are facing in India is the drug resistant, and in some states, especially in the northern India, we're facing a resistance almost up to 10%, whereas in southern India, from which I come from, which is somewhat a richer part of the country, fortunately, the incidence of resistance is much less and compliance to drugs is much better. Now, a lot of these patients are treated conservatively with anti-tuberculous drugs, and they do very well. Now, here's a patient who developed again tuberculous infection in his lumbar spine. Fortunately, in the lumbar spine, tuberculosis of the spine, it behaves differently to the thoracic spine. There is usually not much of a deformity because here there is more subsidence of the vertebra than bending of the spine. So that would again preferably give us a very satisfactory result of good sagittal alignment after completion of the treatment in these patients. However, if they are not responding to the drugs, again, as you can see here, see this is a lung. This guy is a chronic smoker. So we did a thoracotomy, we cut the diaphragm, we went to the front, again, excised the whole of the diseased vertebra, created a cavity there that you can see this is the cut diaphragm. You can see that there's a marker stitch there, there's the lung. And then we went in, debrided the vertebra, and then we put an iliac, we took an iliac crest graft, and then we placed that graft here in the defect. Sometimes, as I said, we put a cage nowadays and screw construct, and that would give us a strong anterior construct. Even without that, you could see that there's at 6 years post-op, you can see a solid fusion of this tuberculosis patient at the L3-4 area, L2-3 area, and he has done very well. Sometimes in the cervical spine, this is a medical student, she had tuberculosis of the lumbar spine as well as the cervical spine. We were treating her, we operated on her thoracic spine, the lumbar spine, decompressed it and fused it. In a few weeks, the cervical spine disease progressed in spite of continuing antibiotics and giving her a cervical orthosis. So we went from the front. You can see here the abscess. We did a partial corpectomy. We put a graft here, anterior cervical graft, and then we put a plate and fixed it in this medical student. And she went on to do well. And as you can see, gradually her disease subsided both in the lumbar spine as well as in the cervical spine, and we had a solid fusion of the healthy vertebrae and complete eradication of the disease. Now, what about the thoracic spine? As I said, I'm a bit more aggressive when I see lesions in the thoracic spine, situations like this where there's an anterior abscess, but that's not a problem. We usually drain these abscesses today. You can see that also clearly on the X-ray. We use a CT guidance and drain most of these abscesses and treat these patients conservatively. But when there is a progressive thoracic kyphosis, as you can see here, that is a danger sign associated with an abscess causing compression on the spinal cord. And if they develop any spasticity any early signs of spasticity in the lower limbs, or any early bladder changes, bladder dysfunction or bladder problems, we should not wait. We should go in, and whichever route, either anterior, posterior, or posterior with the anterior approach or a combined approach, you should go in and decompress the spinal cord, and you must correct the deformity at the same time. As you can see here, there's a dissection of the vertebra. There is an abscess in the spinal canal, and there is a prevertebral abscess as well. So this was again treated. You see a laminectomy there. We drained we went through the pedicle. We debrided the whole of the disc space from the front, either through usually we do a bipedicular approach, and then we take out all the tissue, the dead tissue, the necrotic tissue, and we push in a lot of bone graft through that, to the pedicles. And then also we sometimes use the transpedicular route to push bone graft, and then we stabilize the spine nicely with pedicle screws. Sometimes we put screws even into the infected vertebra, a short pedicle screw like we do in trauma, and augment it, and then continue them with antituberculous drugs. Again, in situations like this, you see this small child here. You see this is the brain, this is the spinal cord. You can see this is the odontoid, that's the C1, and you see the extensive destruction of the apical, the cervical vertebrae, the C1, C2, C3 area in this child, and she was paralyzed. And that's a CT scan. You can see here that in the CT scan, you can see where the odontoid is. It's gone into the canal, and there's a significant destruction here, and that's a C1 vertebra there, and you can see all the destruction of the facet joints at occipital cervical junction. So in this situation, I initially put sublaminar wires under C1, C2 and stabilized the cervical spine with these cables. And then I turned hand to the front, and then I did an anterior approach. You can see here, you can see all the tuberculous thick pus. This was all excised and cavity thoroughly debrided, and then a graft was placed in that cavity that was created, the dead space, after thorough debridement and decompression of the spinal cord. So we debrided and went in right up to till we could see a good decompressed spinal cord. And I turned hand again on her posterior side, and then we opened up, and then we did a occipital cervical fusion. So this is a case where we went from behind, stabilized the spine because, again from the front, put these screws as a caps, but we could not rely on this anterior fixation. So we had to turn her around because this is a flimsy fixation. So we had to turn her around and then do fixation from behind as well. And this child did well eventually with antituberculous treatment, and we kept a close watch, and fortunately the implant did not fail, and she did well. Again, another situation, this is in a slightly older guy, is about, I think roughly about 35, 40 years age. Again, you see here the destruction of the infection in the cervical spine, the compression of the spinal cord, as you can see here. And he also had infection in the thoracic spine. So again, in this situation, we went in, we decompressed the spinal cord, and then we instrumented the thoracic spine. We put some cross links to increase the stability of the fixation, decompress the spinal cord. And again, we did a complete decompression from the front and as well as from behind. And then we instrumented only from behind because most of the vertebra was not too bad in this situation. So the anterior cervical vertebrae were quite okay. So we were happy with the decompression in the front, followed by instrumentation from behind. All this was done in a single sitting. And fortunately, this guy went on to do well. Most of the tuberculosis of the spine, as I'm sure my colleagues from Egypt are aware. It's a very easy disease to treat, and most of these patients do well. And fortunately, with today's medication, it's become less, more forgiving and less dangerous. Now, again, another case of thoracic spine infection, thoracolumbar junction. Again, you see here, this is all posterior approach, correct instrumentation, maintaining the sagittal balance, as you can see here, as far as possible. So not only treating the infection, but also making sure that they get a good thoracolumbar alignment in their spine when we instrument them. Now, what about the neglected cases? We in India see quite a few neglected cases. We also have a few series of cases of late onset paraplegia that we see many, many years after treating them for tuberculous infection of the spine. Because of the gradual progression of the kyphosis, there's a pressure on the cord from the anterior knuckle, and stretching of the spinal cord on this knuckle causes gradual spasticity and weakness, and they come to us with paraplegia, a slow progressing paraplegia. And this, fortunately, these patients are less because of the improved medical facilities in India, and much more educated population, and as a country getting slightly richer and more financially, people are much better off compared to about 20 years ago. So that has led to a lot of early referral to doctors, and public healthcare and private healthcare taking over. These cases are becoming less and less nowadays. Now you see here, this is a, I think about 19-year-old girl, 22-year-old girl. You can see here what happened. She developed tuberculosis in childhood, and you can see the deformity of the spine, and you can see how much of cervicothoracic kyphosis that she developed. These are real dangerous situations. If they come to you with paralysis, there is no problem. If they are not paralyzed, there is not much of a problem. If they come to you with paresis, that means if they come to you with weakness, partial, they are walkers with mild spasticity, you operate on them and they become completely paralyzed. That's a disaster. So you need to be very careful. I tell my team of doctors to be extremely careful when it comes to partial neurological deficits. Now, how did I manage this situation? You see here. So that's the complete destruction of the bone, but there's no active infection here. And you see here the kinking of the cord on the corner of this vertebra here. And you see the myelomalacia. You see there. And the long syrinx developing there. And then she was getting weakness in the lower limbs. So that's the situation. There's a bit of edema, there's a bit of syringe there, and damage to the spinal cord. So here we went in from behind. This is a case that we did long time ago. Again, we put some what we call these lateral mass screws and some thoracic pedicle screws, augmented with a lot of bone graft, autograft. We also use a lot of synthetic graft. We decompress the spinal cord from behind, and then to increase the stability, we use these transverse connectors. And then see, that is and all from behind, we decompress the spinal cord. We excised we went in from the side very carefully. We excised the pedicle, decompressed the spinal cord, all from behind. And then that is the area of decompression, as you can see here. And we went in from the side. We were very fortunate, all through spinal cord monitoring, and we could decompress the spinal cord and instrument it. As you can see here, these are the lateral mass screws and pedicle screws. And then you can see that we could create a good cervical lordosis and maintain the thoracic kyphosis. That's what we do in this situation. Now, you see here, this, as you can see here, she's actually 26 years old when we did this surgery. And the child, this child is from African country, Tanzania. We don't know what happened in the past. This boy came to us. There was a language issue, but there was fortunately an English translator for us. This child apparently had a tuberculous infection, and he came to us when we did a CT. You can see here that there's a bit of bone here. We thought it was initially a congenital problem, kyphosis, but the mother was quite sure, the caretaker, that there was a spinal infection, and that was treated with some traditional medicines in Tanzania. Now, this child was very small and very thin boy. He developed paraparesis. He was about grade 3 power he had in the lower limbs, and he developed bladder symptoms. So this is one situation where I was mentioning earlier when Masa was talking. We use this robot, you see here, and we use this robot to put these screws in the spine. And these are one of our early cases. We put these wires with robotic help, and this is the robotic arm that fixes the screws. And this is the screen that you do. So this is the grid. You do a CT scan. You feed it into the robot, the computer that will select the length of the screws for you and the direction of the screws. And all you have to do is to put the screw, and the robot would fix it for you. Now, as I said, I more or less stopped using this. It has a tremendous long, lengthy curve. Now, to put these screws, 6 screws, we took about 5.5 hours. And what we would do in a freehand technique. So, and also it's wrong to do these sort of cases with robot in the early stages, because it's, I think you should pick up very easy cases initially and then go on to these cases. So I use most of my work in freehand, though we have navigation systems and all that. I prefer freehand technique. As you can see here, what we did, that's the curve, that is the initial rod to stabilize the spine, to see that it suddenly doesn't translate or collapse. We put this temporary rod, then we excise during a laminectomy and expose the whole of the spinal cord. Then we go from the front of the spinal cord and excise. So we do a vertebral column resection, completely excise the whole of that vertebra from the front as well as from behind, did a good vertebral column dissection, and then close the osteotomy. And you can see that this curved rod has become more or less straight, and we could achieve, see this curve here, this sort of curved deformed spine, we could get a very good correction of that kyphosis. This is what we do. We do a vertebral column dissection, and then if there is any gap, we fill with bone graft. And sometimes we put a cage, but this boy was too small, and I was quite pleased with that correction, with this robotic correction and VCR on this small child. Another case you see here, this is a kyphoscoliosis. You can see here, this girl was a 12-year-old girl, and then she was about 87 kilos in weight, and you can see here that she has a huge lump of fused spine, and that's her kyphosis. She came to us with just bladder symptoms, and this was operated, and we corrected the deformity, and we put these screws, and at that time we did a mistake. We were very happy with the correction. We didn't realize that this child is 87 kilos, a short girl, and we didn't put enough screws. This is a problem bound to waiting to happen. And as you can see here, the rods broke. You see that? And then the deformity recurred. And then she got worse neurologically. So she started developing tingling sensation in her lower limbs and electric shock-like sensations. So you could see the deformity. So this is a technical mistake. We could have put screws, more screws. So it's very important that any young doctors who are listening to this talk, you should have lots of screws near the apex of the deformity. Though it looks good on these heavy children, it's very important that if you don't populate these vertebrae with enough screws, the implants break, and that would be a problem. So I had to remove these implants. As you can see here, completely we removed these implants. I exposed the spinal cord. I put the temporary rod here. I decompressed the spinal cord. We removed the whole of as much of the bone from the front of the cord as possible. As you can see here, I pass my instrument from in front of the spinal cord. So thorough decompression of the spinal cord from the front, from the front, all from the posterior root. So temporary rod, laminectomy, decompression of the spinal cord, careful use of osteotomes and burr to decompress the spinal cord from the front. And then I turned the patient around, did a thoracotomy, excised the vertebra from the front, did a vertebral column dissection of both anterior and posterior, and then instrumented with
it's 21 hours.
Vertebral screws from the front, and then we achieved this correction. So this is the the anterior surgery, grafting, excision of the vertebra, and then stabilizing with screws. And this is the posterior instrumentation, gradual thoracic kyphosis to lumbar lordosis, augmented with the transverse connectors. Here, I didn't have to bother about putting more screws here because I was relying on the anterior instrumentation. I'm a big fan of anterior surgery. I would do a lot of surgeries that were shown by our colleague from China. I do a lot of anterior work in those sort of situations. So combined VCRs and the resections is my preferred method of treatment for rigid spinal deformities. What about post-op spinal infections? I will move on to the last part of this talk. Post-op spinal infection is a surgeon's nightmare. This is the dreaded complication. We do a good surgery, we go home, and when the patient comes back to us with infection, we are devastated. It is only less worse than a neurological deficit or a blindness that we see sometimes in our careers. Much has been written about this topic, and much has been advocated to prevent these infections. But over the years, both the literature and the experience of the surgeons in dealing with this problem has come to a standstill. We have no answers. We are no better than what we were doing about a decade ago. And I cannot think of any new antibiotics on the horizon. So no new antibiotics, no new techniques, no new methods of dealing with this problem that are proven in clinical situations in the last 10 years. And unfortunately, with the complexity of the surgeries increasing, and with the complexity of surgeries that we are doing with experience, complex deformities, complex osteotomies that we are doing, infection is a nightmare. Now, about 8.3% of these infections are mixed infections. That's a bigger problem. So a single organism is mostly the one that we see. And in my practice, in the last 600 cases, they have just published our work, 80% of our infections, or more than 80%, are gram-negative organisms. We need to rewrite our textbooks. Staph aureus is no more the common pathogen, no more the commonest pathogen, at least in our institutions. A lot of antibiotics are given to patients for coughs and colds, and they are developing resistance. So most of these infections today are gram-negative, multi-drug resistant bacteria, and these gram-negative infections are such a nightmare for us to treat them. So it's very important that we take care in preventing infection than worry about how to treat a patient, especially when a complex surgery that you do. Now, the incidence in the literature varies from 0.7% to 11.9%. The type of surgery is the most important variable. That is very important. Lumbar discectomy carries about 1% to 3% infection rate. Now, younger the healthier the patient, lesser the infection rate. Short duration in this situation, lumbar discectomy, less muscle stripping, so less infection. So if you do a long surgery without instrumentation, your infection rate goes up to about 1.5 to 2%. That is long surgery up to 3 levels without instrumentation. If you add hardware to a long fusion, your infection rates go to 6 to 8%. I am talking about otherwise healthy people. Now, if you use a graft, an iliac crest graft, the graft site infection is roughly about 1% or less than 1%. So that is the overall infection rate that you see after surgeries. Again, what are the factors? Extended pre-hospitalization. If you have your patient in the ICU for 4 to 5 days, there's a much higher chance of infection. So you need to get them out of ICUs as soon as you can. 100 ml, 1000 ml blood loss or more than that, there's a higher chance of infection. Any surgery that's more than 3 hours, there is a higher chance of infection. That's why surgeons who work in teams, if you have long instrumentation that you need to do, if you do a fast surgery, if your colleague is operating on the opposite side, you can freeze the surgeries faster and you'll have lesser infection rates. As I said before, do not admit patients for 2 to 3 days before surgery, doing blood tests and CT scans and MRI scans. You should admit them at least either on the same day for simple surgeries, like not simple surgery, but less complex surgery like a straightforward discectomy, or the night before. You should also address the malnutrition. If you're doing any complex deformity surgery, you should address both protein and protein calorie malnutrition. Some of these patients, I put them on protein supplements for 3 to 4 months because protein malnutrition is associated with poor wound healing. If you see a lot of these congenital early onset scoliotic patients, they're very thin, they're small, they eat less, and because of their gastrointestinal problems, and they are again more prone for infections. They are also the congenital scoliotics, early onset scoliosis, are well known in literature for poor wound healing. So make sure, optimize your patient before you take them up for surgery. And also increased infections are common in patients otherwise who are suffering with kidney infections or undergoing renal, dialysis or immunosuppressed due to chemotherapies for cancers or post-transplant patients. These are all patients who are potentially susceptible for developing infection. If you, again, we assess the albumin in most of our patients for complex surgeries. If it's less than 3.5 grams per deciliter, that is malnourishment, and you need to improve that. Pre-albumin response more rapidly to treatment may be used as a measure of successful ongoing nutritional treatment. Also look at the total lymphocyte count. If it's less than 1500 to 2000 cells per cubic millimeter, that indicates malnourishment. And be very careful with smokers. We all know that they're prone for fusion failures, chronic smokers, but they're also prone for more infections compared to non-smokers. Rheumatoids, uncontrolled diabetes, obesity, we all know these are fundamentals of spine surgery or any surgery, and we should be very careful. Today, we see a lot of patients in India who are very, very obese. In fact, in the cities, obesity has become a big problem with the economic condition improving every year in the country. The obesity is becoming a big problem as well. Now look at the studies by Feiqiu and Lee. They found out, they studied the risk factors for surgical site infection after spinal surgery. They did a meta-analysis, 12 studies, 13,476 patients. And what is their conclusion? They said nothing new out of this meta-analysis. Diabetes, prolonged operative times, BMI of more than 35, posterior approach, number of intervertebral levels more than 7. So nothing has actually come out of this meta-analysis that we know for the last 15 to 20 years. So this is again an interesting study. In 2019, last year, risk factors for surgical site infections after posterior lumbar fusion. These are much more prone in the lumbar spine. Again, diabetes mellitus, p-value 0.031. Low preoperative calcium level of blood plasma. This is a very interesting finding. So this has a relevance on the one of the risk factors for surgical site infection after posterior lumbar fusion surgeries, and this is what we should look into. And as I said before, low preoperative and postoperative albumin levels. And again, this is a very interesting one. A high glucose concentration in the early postoperative period. That's also very well known. A low postoperative hemoglobin level is also an important factor. So this study has thrown some light on preoperative calcium monitoring as well as postoperative hemoglobin level and a posterior lumbar fusion and infection following that. The other one are the risk, again, in the same study, 3 or more spinal segments as a significant chance of getting surgical site infection in the elderly patient. Now, amount of blood loss again is well known, and this is another factor we all know. You keep drains for a long time. We all use blood thinners after surgery, and they keep oozing, so we keep these drains for a long time, and again, they are well known to cause infections, postoperative infections. So early drain removal, early mobilization, quick surgery, quick, getting them as late as possible to admit them for surgeries and discharging them as early as possible. These are the methods of preventing infections in our patient population. Now, you see here, sometimes it's not only what we do, it's also the the environment that which we operate is extremely important. We need to have very good quality theaters. We need to have the laminar flow theaters if you can afford them. Good monitoring of the theater environment. These go a long way. Otherwise, you do a good surgery and a patient develops infection. That is not a good sign. CSF leak. In spite of our best efforts, these are problems inherent in spine surgery. And again, these are all patients sometimes prone for more infections. This is a girl who came to us. She had previous surgeries to correct her spinal deformity. You see these multiple scars, the thoracotomy that was done before. And she had lots of infection that we needed to debride. We thoroughly debrided her spine, and we got a infection under control. And about 8 months down the line, we corrected her deformity as a second stage. And again, we have to be very careful. This is a child with Marfan syndrome that we operated. There was a tremendous tissue necrosis, and the whole of this paravertebral musculature got infected. There were large hematomas. And fortunately, we did repeated debridements, and then the patient went on to do well. He's now a grown-up man, and he got married, and he's doing very well. And during the postoperative period, he gave us a tough time. Again, neuromuscular scoliosis has a morbidity rate of mortality rate of almost 20% depending on the type of neuromuscular scoliosis. And they have infection rates going up to 20%. So early onset scoliosis is a term coined by the Scoliosis Research Society. I myself do not like that term because there's a mixed bag of patients here with different problems and different pathologies, and they need to be addressed in different ways. But suffice it for me to tell you that neuromuscular scoliosis has a much higher infection rate, and you need to be careful. So what about stage spinal surgery? Mengelbaum in his studies, 87% malnutrition, and he found that 27 out of 28 infections occurred in stage surgeries. So that's because they say that hospitals stay longer and infection rate higher in the stage group. And he recommends the same day surgery whenever possible. It may not be possible in every situation. So now previously I used to keep these patients in the hospital and do the spinal deformity correction in 2 stages. Now what I do is I discharge them after their first surgery and then bring them back after 2 weeks or so, and then do the second surgery as a second stage. And I had no problems doing that. And the patient once goes home and comes back, they're much more better psychologically as well, instead of keeping them for long days as I used to do in a long time ago. So how do you diagnose it? Discomfort at operation site. A high index of suspicion is extremely important. They're initially okay, followed by discomfort later on. Most present 10 to 15 days after the index procedure. That means they go home and they come back after 10, 15 days. It's a slight discharge or warmth or mild constitutional symptoms. Usually there is no fever, contrary to what the textbooks tell you. There could be some signs of inflammation around the edges of the tissue, edges of the wound, the surgical wound, but most times these sites, the surgical wound looks healthy, but it is not. There would always be an ESR elevation, and more important is the CRP. As a rule today, I do CRP on all my spine patients before surgery because you see here, whenever there is an infection, the CRP goes up in 2 to 3 days and reaches a plateau. So we can also know the response to our treatment by about 17th day. Whereas if you take up ESR, it takes a much longer time. It takes about 5th or 6th day to reach its peak and then plateaus around 3 weeks. So CRP is a much early indicator, not only of a suspicious infection, but also a good indicator of response to treatment, surgery or medical or a combination of both. So the best imaging modality is an MR. That's what you should be doing. Now, how do you diagnose a post-operative infection from the routine operative changes that you see? Whenever you suspect an infection, it should almost always should be a contrast enhanced MRI. Routine MRI should not be done. You always remember three signs. One is enhancement at the disc space. You see here, that's the enhancement. And you see the enhancement of the end plates of the vertebra. That is edema. So if you see a combination of edema at the vertebral end plates, enhancement of the disc, and the epidural fluid, this triad indicates infection. Don't think that is a sign of routine post-operative changes. Always look for these signs on MRI, contrast enhanced MRI, good quality MRI, and then correlate them with your clinical findings and the blood parameters. So antibiotic prophylaxis. So how do I prevent these infections? What is my antibiotic prophylaxis? Please maintain high discipline. This is very important. This cannot be overemphasized. If it's a clean wound, what should you give? If it is clean but contaminated, what do you do? And if it's completely contaminated wound, what is your prophylaxis? If it's completely contaminated or partially contaminated, the prophylaxis should be always be guided by the antibiotic cultures. If you're awaiting antibiotic culture, you must give a broad spectrum antibiotic. If it is a clean wound, if you're awaiting culture reports, a second generation cephalosporin added to that with a aminoglycoside injection is a good initial cover. So what is a clean case? No skin break, no entry into respiratory, intestinal, or genitourinary tract. The risk of infection in this is only up to about 1 to 1.5%. In clean cases, people have advocated clindamycin, to lincomycin, to gentamicin and vancomycin. Lots of combinations have been suggested in the literature, but most situations, cephalosporin, and sometimes a combination of aminoglycoside should be all right. I used, in 2005, I read this paper of using 3.5% betadine solution. Ming et al., they studied 414 patients, 208 patients dilute betadine. The 3.5% betadine solution apparently does not harm the osteoblast, and that would not damage our chances of fusion. So that is a good solution that we use. And in their series, they just had 1 superficial and 6 deep infections. But our own series, in spite of using 3.5% betadine solution as a routine in the last 15 years, our infection rate is a bit more than Ming's series. Now, early diagnosis is extremely important. Do not procrastinate. Do not procrastinate. Start antibiotics, do cultures, and you'll end up with a good result. Sometimes if you have an infection like this, as I showed you before, it is a case I went for the anterior approach. I debrided the disc spaces completely, debrided the vertebra, and filled them with these iliac crest grafts without instrumentation. That's all I do, and they do extremely well. Sometimes if there's an infection after a discectomy, you could do the screws to stabilize. This will take control of the mechanical severe pain that they get, and you can augment that with a interbody grafting, or you can put a cage depending on the type of bug that you grow in the lab. So I use a lot of interbody fusions without cages when I am not sure of the infection, and they do very well with this stabilization. Sometimes you find patients coming to you with pouring pus from the wound, and you look at it and you see that, and I'm sure some of you may have the experience. You take it out, and that's a leftover swab. So this is sometimes you see in our career. These are some cause for a lot of embarrassment, and you always wish that these things happen to your best of friends or enemies, but it can happen to you if your team is careless, because after long surgery we leave it to our juniors to close, and fortunately this is from a colleague of mine in the city, not my patient, but one has to be very careful. Now you see here, this is a 35-year-old lady, very heavy lady, L5S1. This is a grade 3 listhesis, not 2, it's a grade 3 listhesis, and we reduced that listhesis. We got almost anatomical reduction. We put these expanding cages, and we got a very good result. We could a good localized lumbar lordosis we obtained. And you see here, 8 years later, she came to us with pain. We identified that there was a screw that became infected. All we did was to remove that screw, and she had a good result. Last few slides. In the presence of implants, non-operative treatment is rarely indicated. You must always give appropriate antibiotics, debride early, open up all layers, leave the metalwork and grafts in place. Do not remove the metalwork. Keep deep and superficial drains, and do a primary closure. Here's a guy I operated with severe lumbar spinal stenosis and claudication. You see here, there was an infection from the iliac crest graft site. So we opened up all the layers. You can see here, we removed all the the unhealthy tissue, debrided it, and they left the implants alone. And you could see here we drained the abscesses, and fortunately he went on to do well. Here's a patient of again infection of the spine. This was treated anteriorly with an iliac crest graft. You can see the graft here nicely, and then posterior instrumentation. You see what happened here. The patient, after a while, the disease has healed, but there was an implant breakage. There was a pseudarthrosis here on a CT scan, and she developed a lumbar kyphosis. So, and she developed severe pain. She was about 102 kilos. So I went in, I did a thorough decompression of the spinal cord. You see here, we did a pedicle subtraction osteotomy. We decompressed from the front, and then we excised the whole of pseudarthrosis and filled up with bone graft. We corrected the deformity. We closed the deformity by sequential compression of the posterior implant. And you can see here, I got a nice lumbar kyphosis, and we put in a lot of bone graft here, all from the posterior side. And we thought we had done a great job. But 8th postoperative day, there was oozing, 102 temperature, cultures grew E. coli, and again the problem came. So we went in, thorough wash of all layers with 3.5 Betadine solution, used about 10 liters of saline. I used minimum of 6 to 8 liters of saline to wash placed drains. The pain decreased, temperature returned to normal. We continued with antibiotics. And you see at 1.5 years, she healed up, and she went on to do well. And at 8-year follow-up, she is asymptomatic. So these infections are dreaded complications. Again, another, as you can see here, a very old lady. She had a vertebral fracture. This was augmented with a vertebroplasty that got infected. They removed a lot of cement. They put screws from the front. The infection continued. There was epidural abscess. The surgeon went from behind and then debrided it, put screws. Again, the whole thing got infected. It was a huge, big problem. So she underwent a vertebroplasty, 2 debridements, anterior instrumentation, posterior instrumentation. All this failed, and I was called in at this stage. I removed the whole of the implant, and from the posterior side, you can see the anterior implants. This is a very rare sight in spine surgery. So I removed all the bone cement and the screws as well, which is unthinkable, all from behind. I put spanning rods here in the healthy bone, and then we continued the antibiotics, and then she became a paraplegic. She never recovered from her paraplegia, but fortunately the infection got completely controlled, and then she became all right, but was wheelchair bound for the rest of her life. Now, he's a child with kyphosis, as you can see here. I was pleasantly surprised with Dr. High's results of complications following kyphotic deformities. I think his team has done a wonderful job, but life is not that easy. Life is not that easy. We have a huge experience of treating these kyphotics, and they have huge problems. And I've seen these problems in my training abroad and my stay abroad in the big spine surgery centers. So I think he's very fortunate. You see here, we do a good surgery. This is a very long time ago. And then the skin breaks down, you put this wax, and then you take the help of plastic surgeons, you do latissimus dorsi flaps, you need to control the infection, you take the help of plastic surgeons, and give a good skin cover. You see here this complex deformity. You see the scoliosis and kyphosis. Yes, we do a complex osteotomies and we get a good result radiologically. We do a complex, this girl underwent almost about a 9-hour surgery. This was in 2010, as you can see there on the X-ray form. The picture is slightly reversed. So 2010, and you see here, the whole skin broke down. So again, we had the problem, all the implants were seen. We retained the implants. We took the help of plastic surgeons. Fortunately, We had a good latissimus dorsi cover, and then that was closed with skin grafts and all that. This is an extremely rare complication. In my career, I've only seen 2 cases of post-operative fungal infection in healthy people. Now, this is a case that a surgeon would never see. This is a case that I did in 2019, just last year. And as you can, she's a very healthy 47-year-old lady, no comorbidities. And you see here what happened. You see this cyst that she's developed? She came to me with fever, and I thought it was routine post-op infection, and I debrided it. I sent it for culture. This is Aspergillus terreus. This is almost never reported in literature in healthy people. These are a contamination. And this was another hospital that I work. And usually this fungus, apparently on literature search, grows in construction sites. And you can see here, this lady is only 49 years old. So what we found then was we investigated, and they were repairing in the theater complex 2 adjacent theaters, and they were modernizing these theaters with an MRI suite and all that in this hospital. And perhaps there was some connection between the refurbished theaters, brand new theaters, and this theater, and maybe the fungus went through these air conditioning tubes, and the infection control specialists and the pathologists, microbiologists were wondering about this infection, how we could get this, but now we have 1 year follow-up. Fortunately, she's doing well. I conclude by saying that spine surgery, as was told by my speakers earlier, should be an interdisciplinary approach. When you have an infection, you need to have good infectious disease specialists, you need interventional radiologists, and you need a good team of spine surgeons. A good operating environment for those of us who are not fortunate to work in, be working in very wealthy countries of the world, but we are also progressing. We are not lagging behind. We are improving by leaps and bounds in our facilities and in the technology. And today in India, I'm very, very proud of the work that is done by the members of Association of Spine Surgeons of India. We are now second to none. So efficient teams are developing in all parts of our country. We have good post-op backup. We have intensive care specialists, pulmonologists. We have respiratory specialists, pediatric respiratory specialists, etc. in the cities. And as I said before, early debridement, appropriate antibiotics, and a very aggressive approach is what is needed to deal with this much dreaded problem. And to come out of that, you need to spend time, think, and then not to procrastinate and be aggressive in your management. I thank you once again for the opportunity given to Benha University and to Professor M.Ch. And I sincerely thank Professor Galal Kazim and Professor Ikmal Akbar and Dr. Ahmed. Thank you very much.
Thank you so much, Professor Raghava Mulukutla from Hyderabad, India, for this very interesting talk about very important topic in spinal surgery. And thank you again, sir, for accepting our invitation. It was a great honor to us, sir.
Thank you.
Now we come to the questions. Professor Mamdouh Karamani is with us.
Okay, Dr. Muhammad, hello.
Yeah,
Hello,
I hear you, sir.
Muhammad.
I hear you, sir. Professor Mamdouh? Professor Ashraf?
Yes, I'm with you.
Can you start the moderation, sir?
Thank you, Professor Mulukutla, for this instructional course. Actually, for this very difficult and very annoying, and it's the nightmare of any surgeon and any spinal surgeon. There is a question from Professor Muhammad Mazyad professor of spine surgery in Ain Shams University, one of the heroes of spine surgery in Egypt. Thank you. The fixation from D11 to S1, I think there was a case with a fixation from D11 to S1 for localized segment infection.
Yes, I would like to.
Is very long. Moving disc are remaining at lumbar region. That will be complicated by adjacent kyphosis in short period of time. Professor Muhammad Majid. This is his comment and question.
I totally agree with that. We don't do that sort of long segment fixations. We have seen these situations where the kyphosis progresses, especially in the elderly population. We don't do that. The reason why we did this was he had a significant lumbar spinal stenosis below. And that's why we did that as a prophylactic measure. I completely agree with the professor. We don't need to go that long. This was an overkill. I agree with that. Yeah.
Another question from Dr. Ibrahim Qamar from Ireland. Do you believe in effectiveness of vancomycin immersed implants as a prophylactic measure? Preoperatively, there is some literature describing this technique.
Yeah, that's a disaster. That's a disaster. I have used vancomycin and I stopped using it. The minute we use vancomycin, I feel that the gram-negative organisms are taking over. I'm sure you agree that if it is a Staph aureus, you have a long list of antibiotics that you can use to take over, to eliminate Staph aureus infection. Even if it is MRSA, we have a few drugs that we can use. So by use of vancomycin, we are actually making the gram-negative organisms come over. And that's my paper now. I do not encourage use of vancomycin at all. That's very important because we have seen emergence of gram-negative organisms. And these gram-negative organisms are such a violent bugs because when we see the culture sensitivity reports, we just see one or two. And there are situations where in my cases, where there was just a, what you call sensitivity to only colistin. And we gave this colistin to an elderly person who developed E. coli infection and he developed a kidney problem. And we had to dialyze him. And fortunately, we cannot give any other antibiotic because there is no other antibiotic to give. So in my books, I don't have literature study on this, but we have documented our cases where we have used vancomycin. And we have shown very clearly, this is all in our data, which is just accepted for publication. So we have shown that maybe indirectly we are causing the gram-negative infection to come up. And I'm sorry if I'm repeating, it is much, much tougher to deal with a gram-negative infection than with a gram-positive infection. I stopped using vancomycin.
Yes, sir. And in cases of...
Sorry, I just clarify, sorry to interrupt. In clean case, if there is an infected case where we know that there is a Staph aureus is the bug, that's a different story.
Mm-hmm. Yes. In cases of anterior debridement that how can you reconstruct the anterior column? By graft?
Oh yes, I always use a graft. Sometimes we use cages. Sometimes we use graft plus rod, as I've shown. I'm an anterior surgeon. People have forgotten anterior surgery. It gives fantastic results.
Yes, you do the debridement, the discectomy, anterior discectomy, and debridement of the subchondral bone, and you reconstruct with a graft, interbody graft or a strut graft, or you apply a cage
Yes.
with graft.
Cage as well as cage I supplement with vertebral screws.
Yes, and a vertebral screws, and and also posterior augmentation, or you do the strut graft with an augmentation with screws and rod.
Yes, usually if my quality of fixation is good, for example, in tuberculosis, you see a large, at least 2 to 3 levels of vertebrae sometimes are very, very osteopenic. So if you are not very happy with the quality of fixation on the front, I turn the patient round and then I augment them with posterior instrumentation. Usually, they, depending on the quality of bone, either 2 levels above and below or 3 levels above and below.
Okay, did you confront it before with an infection, post-operative infection, in a case with cement augmented screws in in an osteoporotic patients?
Oh yes, it's a problem. It's a problem. Yeah.
How did you solve it?
What I do is I always do 2-stage, always, because once we remove the implants, there are big holes there. There is nothing you can do. And if it is in the lumbar spine, it's easy, because what I do is I remove all these implants, and obviously if they're very unstable, it's a different situation. Otherwise, if it is stable, I turn the patient around and do an anterior surgery to stabilize the spine with instrumentation, because there's hardly any place for instrumentation. And there is, if you fuse the posterior spine with posterolateral infusion, there's hardly any fusion there. And a lot of these patients require, if you have to do a long, for example, 5-6 levels, even if you're using BMP, that would add to a tremendous cost to the patient. So, and BMP, as we know, has its own limitations and problems. So I would easily turn them around to the anterior side in the same stage or second stage, and in a clean bone, I fuse that spine and instrumentate, and I get away with good results. So that is that's what I do in my practice.
Yes. In the case with the aspergillus.
Gaines, Bob Gaines. I totally disagree with his method of excision of the in spondylolisthesis, and I'm also skeptical of the adjacent segment. I had a discussion with him when he came to Delhi in India. Well, I don't agree with everything that is done in the United States of America. My patients are poor, my patients are clever. They question us like hell. So we need to be very cautious, and they don't like too many surgeries. But I really admire Dr. Gaines' anterior surgeries as well. But it's a forgotten art. Surgeons in the Western world now do not know how to operate from the front. And surgeons from India have been learned this technique from Hong Kong. And I was, of course, fortunate to be trained in the Western world. So I was trained in good old days in the 90s. There was a lot of anterior surgery in Europe and US. So that is the surgery that we need to develop. This should be well within the armamentarium of a spine surgeon. So whenever you have problems at the back, you go to the front, you have healthy tissue, and then you can solve a lot of these problems. And you don't need any vascular surgeons, or you don't need any general surgeon to do this. Most of us who are senior surgeons are well versed with these surgical techniques, and we are very comfortable doing thoracotomies even in small babies, children.
Dr. Asher.
Thank you.
Thank you, sir.
Dr. Kazem.
Asher. I would like to thank Professor Raghava Mulukutla for his very nice presentation. I share with him all the concerns about these patients who are malnourished. The situation in Egypt now is a bit better than before. Incidence of tuberculosis is much less. We don't see them as much as we used to do before, about 30, 40 years ago. I would like to ask a small question for Professor Raghava.
Yes, Professor.
Did you see cases of hydatid disease in India, spinal hydatid?
Oh yes, but much less now.
How many cases have you seen?
Oh, in the last 20 years, I've seen just 2 cases. That's all.
Okay.
I'm in a private practice, so I don't get to see. In public hospitals, there are a few, but very few now. Very few.
Because we have in the Western Desert area, which is between Egypt, Western Desert of Egypt and Libya, this is a very common place for hydatid.
Yes.
I have seen 2 cases also, as you mentioned, in my
Right.
experience, which thanks God I managed to remove the cyst intact without
Right.
opening. I would like to point this out for young surgeons who are dealing in such areas, that this is a diagnosis which they should not miss. And they do Casoni test for skin tests for diagnosing such cases, and they should keep it in mind. Thank you very, very much, Professor. I'd like to thank all the candidates and all the professors who have shared in this meeting. I'd like to thank also all the candidates who have participated in attending the meeting. And I'd like to thank Professor Mohammed Al-Ashhab, head of the department in Benha Faculty of Medicine, for his great care and courage to prepare for such meetings, and Professor Ashraf Ismail for his activity, and Professor Madouh Karamani for his participation also. Thank you very much indeed. And we hope we will welcome you in Egypt, in Cairo, in the Egyptian Orthopaedic Association and spinal meetings in the future.
Thank you so much, sir. Now we come to the end of the very